Welcome, everyone. Okay, I'm so glad you could join us. Good afternoon, and thank you. As I mentioned in the chat, I am Cynthia Handrup. I'm the president of the Global Alliance for Behavioral Health and Social Justice. I'm coming to you from Chicago, Illinois. I know people are coming from all over. And it's with great pleasure that I introduce our keynote speaker and our 2020 Presidential Citation winner, Dr. David R. Williams. Dr. Williams is a St. Lucian and American social scientist who specializes in the study of social influences on health. His research has enhanced our understanding of the complex ways in which race, socioeconomic status, racism, stress, health behaviors, and religious involvement can affect both physical and mental health. Currently, he's the Florence Sprague Norman and Laura Smart Norman Professor of Public Health and the chair of the Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. He's also a professor of African American Studies of Sociology at Harvard. Dr. Williams is the author of more than 475 scholarly papers in scientific journals and has edited collections, and his own research has appeared in leading journals in sociology, psychology, medicine, public health, and epidemiology. He was named one of the top 10 most cited researchers in social sciences during the decade in 1995 to 2005. The Journal of Black Issues in Higher Education ranked him as the most cited Black scholar in social sciences in 2008. And Thomson Reuters ranked Dr. Williams in 2014 as the world's most influential, one of the world's most influential scientific minds, based on his scientific articles published between 2002 and 2012. Dr. Williams has been involved in the development of health policy at national levels in the United States. He's held positions in several professional organizations. And Dr. Williams has played a visible national leadership role in raising awareness of levels of the problem of health disparities and identifying interventions to address them. Dr. Williams has appeared on national television, including ABC's Evening News, CNN, PBS, Al Jazeera, the Hope Channel, C-SPAN, the Discovery Channel. His TED Talk, which was released in April of 2017, has over 1.2 million views. And I would suggest that you do yourself a favor if you have not seen this. It's an amazing TED Talk. His research has been featured, or he has been quoted in the national print media, including the New York Times, Time, Newsweek, the Wall Street Journal, the Washington Post, Essence Jet, and US Today. And he was also a key scientific advisor to the award-winning PBS film Unnatural Causes, Is Inequality Making Us Sick? Another gem that you should really view if you haven't seen it yet. So Dr. Williams, it's a great honor to award you the Global Alliance for Behavioral Health and Social Justice Presidential Citation for distinguished contributions to mental health and social justice, and for your distinguished scholarship in advancing our understanding on the effects of racial discrimination on health. And now I'm going to turn it over to Dr. Williams for his keynote address, which is titled Stress and the Mental Health of Populations of Color, Understanding the Role of Traditional and Emerging Stressors.
I want to say a profound thank you to you, Dr. Cynthia Handrup, for your very kind words of introduction, and to the entire organization for bestowing this significant honor on me. It is my honor and pleasure to be here with you today and to share some of my own research, but research in the general area that I think we all need to be aware of. And I'm very sad that this has taken place not under the conditions that we ideally would have liked. But I'm trust that everyone is doing well and keeping safe. I'm going to share my screen and so that we can look at my slides and quickly go through the talk, and then I'm sure we will have some time at the end for questions. So as Cynthia said, I'm talking about stress and the mental health of populations of color with a focus on understanding the role of both traditional and emergent stressors. Peggy Thoyce wrote a wonderful paper of what we had learned about stress research for over the last 20 years. And one of the points she made was that we understand that stress is comprehensive. It's not just acute experiences, but we need to take into account the chronic ongoing difficulties, traumas, and as well as thinking of the psychological and social moderators that play a role and can be a exacerbating or protective role. But one of the important points she made that I'm going to pen a lot of my talk about is that failure to measure stress comprehensively dramatically understates the impact of stress on health. And I want to talk about some of those dimensions of stress that historically we may have neglected that have emerged as very important. One of them is experiences of racial and ethnic discrimination. Martin Luther King said, "Discrimination is a hellhound that gnaws at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as the truth in the society dominating them." Now, he was not a social scientist, but this is a hypothesis that we can test it. If this is a phenomenon that's a hellhound gnawing at people in every waking moment of their lives, it's not an unreasonable thing to think that it might have some consequences. What are the levels of discrimination in the United States? I'm going to draw on a report from the American Psychological Association that used measures of discrimination that I and my colleague James Jackson, who we recently lost at Michigan, developed and implemented. So the APA found that 69% in 2015 of all American adults reported that at some point in their life, they had experienced discrimination. It also assessed discrimination as acute life events. These are the measures we developed. Questions like discrimination at work at any time in your life. Have you ever been unfairly fired? For unfair reasons, not been hired for a job, unfairly denied a promotion? Have you been unfairly stopped, searched, questioned, physically threatened, or abused by the police? A number of experiences, and if people report them, we would normally ask how frequently, when was the last time, how many of these experiences you've had. Just to give you a sense of a picture from the APA's national data, they found that these are the percentages of American adults reporting they have experienced these unfair treatment experiences at work. And you could see Native Americans, 35%, and African Americans reported that they have been unfairly not hired for a job. That is also true for 25% of Latinos and 22% of Asians and 18% of whites. So you can see the levels of discrimination are common. Here is the question about, have you ever been unfairly stopped, searched, questioned, physically threatened, or abused by the police? And you could see in 2019, 39% of African-American males said they had that experience, compared to 25% of Latinos, 9% of Asians, 15% of whites. Now, the discrimination is not just in those big things, but also the chronic, ongoing discrimination that occurs in the routine activities of life. This is the Everyday Discrimination Scale. Today, it's the most widely used scale globally to assess discrimination, and it's one of the scales I developed to capture just the little day-to-day indignities. Being treated with less courtesy and respect than other people, receiving poorer service than other people at restaurants or stores. People act as if they think you are not smart, or if they are afraid of you, or they think you are dishonest. It's little indignities, and the findings with this scale have even surprised me as to how strong they are and how these little indignities chip away at not just your dignity, but at your health on a day-to-day basis. This is from the APA study in 2015. 34% of Native Americans said they experienced these experiences almost every day, or at least once a week. And we see about almost 25% of African Americans and 20% of Latinos also report those experiences. 61% of all Americans reported they have experienced everyday discrimination. Now, what are the pathways that everyday discrimination might matter for health? Well, these negative experiences of which someone is aware, it can trigger negative emotional responses and distress that increase risk of mental disorders. These negative emotions can also lead to biological dysregulation and contribute to the development of chronic physical illness. Coping with these negative emotional states can lead to increases in risky health behaviors, and these experiences can lead to disengagement with the healthcare system. And research has documented all of these pathways matter. And I just want to give you examples of what research has documented for discrimination more broadly. Here is a study from the United Kingdom that asked minority individuals about their experiences of discrimination. And what this study found was that there was variation across different ethnic groups in the UK. Black, African, Bangladeshi, Pakistani, Indian were the groups they looked at. But importantly, I want to show you the evidence of the cumulative negative effect of discrimination. This is the deterioration in mental health compared to those with no discrimination. And you can see the more experiences of discrimination individuals had, this is a longitudinal study, at more time points, the worse is the greater is the deterioration in mental health. So those who had 2 or more events at 2 time points, you could see the substantial decline in their mental health between wave 1 and wave 4 of this study. What the research is finding is not only the actual exposure to discrimination matters, but the threat of discrimination matters. Discrimination, like other stresses, can affect individuals and affect your health, not only through what you actually experience, but if you anticipate and have to prepare and engage in vigilance activities to protect yourself, there are consequences. So when I developed the Everyday Discrimination Scale, the next question was, in dealing with those experiences you just told me about, everyday discrimination, how often do you think in advance of these kinds of problems that you're likely to experience? How often do you try to prepare for possible insults before leaving home? How often do you feel you always have to be careful about your appearance to get good service, avoid being harassed? You could see there are daily little things that people are doing to potentially protect themselves. And what has research documented? Tom Levis has shown that high levels of vigilance predicts elevated risk of depression and contributes to the Black-white difference in depression. Another study documents that vigilance predicts elevated risk of sleep difficulties, independent of income and education. A study of hypertension finds that actual discrimination predicts increased hypertension, and vigilance also increases hypertension over and above the actual exposure to discrimination itself. One of the things we have learned about understanding the impact of discrimination on health is that we need to understand discrimination over the life course. Here is a study that was done of over 5,000 fifth graders from 3 US metropolitan areas. And these young people, students, were asked, have you ever been treated badly because of your race or ethnicity or because of your color of your skin? And these are, remember, 10 to 11-year-olds in the United States. And you could see 1 in 5 African Americans said they have had that experience. 15% of Latinos, 7% of whites report that. And here are the consequences that are found in these young people. These are the adjusted odds ratios, 2.9 times higher rate of depression in these children who report these experiences of discrimination, 60% increased risk of ADHD, 80% increased risk of ODD, 2.1 times higher risk of conduct disorders. So we are seeing discrimination being experienced at very young ages and the consequences being quite striking. Dr. Naomi Priest from Australia has done a review of the studies of discrimination among children and youth, and published in 2014. At that time, there were 121 studies. Discrimination predicts worse mental health among persons 0 to 18. It predicts inversely associated with positive mental health, predicts elevated rates of problem behaviors and delinquent behaviors, predicts lower levels of well-being, predicts negative pregnancy outcomes. So we are finding a broad range of ways in which discrimination adversely impacts health. Not only does discrimination that young people experience affects their health, but there's research now that is documenting parent-to-child transmission to parental experiences of discrimination are also associated with worsening mental health of children, anxiety and depression that has been documented in multiple studies. And these are a few examples on this slide. We have also begun to better understand some of the pathways by which experiences of discrimination by a parent adversely impacts the health of their children. This is another study from the UK, National Longitudinal Study of Infants, born in the UK between September 2000 and 2002. And this has followed the Black and ethnic minority parents as a subsample, and they were asked questions about experiences of discrimination. So these are mothers reporting the experiences of discrimination they had. And they were assessed their experience of discrimination in 2006. And I want to show you the pathways that have been documented in discrimination in those mothers and their children followed 6 years later. So experiences of discrimination of the mother in 2006 leads to worse mental health of the mother in 2008, which leads to poorer children's socio-emotional development in 2012. Other experiences of discrimination in 2006 directly are linked to worse socio-emotional development of children in 2012. And then still other experiences of discrimination are associated with harsher parent practices in 2008, which is linked to worse socio-emotional development in 2012. So we are now documenting multiple pathways by which the experiences of the mother is affecting the next generation. One of the things we have also learned that I think is very important is that discrimination must be understood and assessed within the context of the broad range of psychosocial stresses that capture the social context and experiences of disadvantaged populations. I remember when I first developed the everyday discrimination scale, people would call me and says, you now have a scale that measures racism. And I would say, no, I don't. It measures some small aspects of racism. It doesn't capture everything, number one. But number two, including measures of discrimination in your study is not capturing all the markers of stress in the lives of our populations. So here is a study that I was involved with. It's a probability sample of adults in the city of Chicago. I worked at the time at the University of Michigan with other colleagues, and we did the study of over 3,000 adults. It's about 1/3 white, 1/3 Latinx, and 1/3 African American. And one of the things we tried to do was measure stress comprehensively. Capture life events like the death of a loved one and financial stress and stress, job discrimination and childhood adversity and work stresses and everyday and major experiences of discrimination and stress linked to your neighborhood of residence and relationship stress. And we had multiple indicators of all of these stresses. And this is what we found. This is representative of the population of Chicago. Both African Americans and US-born Latinos compared to whites, had higher levels of major life events, like the death of a child or a life-threatening accident. Both African Americans and US-born Latinos had higher levels of financial stress, like difficulty meeting monthly payments on their bills. Both African Americans and US-born Latinos had higher levels of relationship stressors, like the frequency of being bothered by problems in relationships or children making too many demands. Both African Americans and US-born Latinos had higher levels of neighborhood stress, and we had multiple indicators of neighborhood stress. And US-born Latinos and foreign-born Latinos, this is the one measure where foreign-born Latinos were high, was an early life stress. In general, we found patterns to be similar for African Americans and US-born Latinos, and patterns for foreign-born Latinos in general look more similar to those of whites. But the exception was early life stress, where they had the highest levels. But this is what we found. This is the number of domains of stress that individuals were high on, and I'm showing you the relationship for self-rated health and for depressive symptoms. And what this indicates is that each additional stressor matters and had an impact on the health. You see this powerful dose-response relationship for each additional stressor that someone was high on and the negative consequences for their health. Emphasizing the point I made at the beginning of measuring stress comprehensively to fully capture its impact on health. What are some hidden ways I would like to highlight in which stressors linked to race and racism have consequences for health that we seldom think about? Dr. Deborah Umberson from the University of Texas has looked carefully at national data. And we know, for example, there are racial differences, disparities in health. So minority populations experience greater loss of life because of the premature death of relatives. And she has been trying to assess what's the impact of this, what she calls community bereavement. And this is before COVID, you know, compared to whites. Black children are 3 times as likely to lose a mother by age 10. Black adults are twice as likely to lose a child by age 30 and a spouse by age 60. All this loss of social ties is a unique stressor. The death of a loved one is a standard instrument on measures of life events, but we don't think of it as a unique stressor that disproportionately impacts communities of color as a result of the elevated rates of disease and death, a challenge that has just been made much worse by the COVID pandemic. Here is another dimension of discrimination. Dr. Brandisha Tynes worked with her on this study, and she's been doing seminal work in this area. But this is data from the first study of online discrimination on the health of young people in the United States, aged 14 to 18. We looked at the level of victimization they experience in text messages and chat rooms and forums and online games and social network sites. And what we were able to document, and now has been replicated in multiple other studies, is that online racial discrimination was linked to higher levels of depressive symptoms and anxiety symptoms in America's youth, independent of a global measure of adolescent stress and experiences of discrimination offline. So we were documenting the unique contribution of experiences of online discrimination to worsening mental health. Here is another study that was published in Lancet a couple of years ago. I did with one of my former students. What we did in this study was try to assess what is the impact of this violence and police violence directed toward Black and Latinx and Native American communities in the United States. And so we linked a database that had every police killing that had occurred in the United States over a 3-year window. And we linked it to another database from CDC that had the mental health of the population in every state. And we were able to show, using a quasi-experimental design, that every police killing of an unarmed Black male led to worse mental health for the entire Black population in the state in which it occurred for the next 3 months. So it's not just that police killings are a challenge and a problem and leads to worse mental health and grief for the family and friends represented by the loss of that loved one. We are showing the entire population effect. And this was a specific finding. It's only police killings of unarmed Black men that had this effect. Police killings of armed Black men had no negative effect on mental health, suggesting that it is the perception of the unfairness and the perception of the injustice that leads to this pattern. There was no effect of police killings of whites on whites or police killings of African Americans on the health of whites. Here is another study going back to my colleague, Dr. Brandisha Tynes. This is a more recent publication where she looked at a sample of Black and Latinx adolescents, 11 to 19 years old, and documented that viewing online these traumatic videos, that is, seeing someone of your own ethnic group beaten, arrested or detained, or being shot by the police, exposure to those online traumas in the prior year is linked to higher PTSD and depressive symptoms. So documenting that these stories in the news are actually directly impacting the mental health of our young people today. I want to give a couple priorities that we should pay attention to before I stop today. One is we need to better understand the health cost of adapting well in difficult environments and learn how we can minimize them. I'm going to share with you a pattern that has been found in multiple studies that suggest that under some conditions, there are costs of resilience. So here's the finding. studies of African-American adolescents followed over time, have found that those who are low in economic status, but have two desirable psychological characteristics, they are high on self-control and self-regulation at age 11, they succeed academically and emotionally in young adulthood. So they are doing well mental health-wise and well academically. At age 20, these young people, they were the poor African Americans who had high self-control and self-regulation, which we think of as desirable characteristics. At age 20, they're doing better emotionally, better academically, lower drug and alcohol use. But they have greater obesity, higher blood pressure, higher stress hormone levels, higher epigenetic aging than their African American peers who were low SES and low on self-control and self-regulation, or than on the higher SES African American peers. And that has now been documented by Gene Brody and colleagues, and Edith Chen and colleagues, and Greg Mill and colleagues. It's been shown in national data, has been shown in studies in specific localities. How do we make sense of this? Desirable characteristics that are linked to some positive outcomes, but are nonetheless linked to some negative outcomes. And it's something we need to better understand. My best sense of making sense out of it comes from the work of Sherman James. He tells the story of John Henry and developed a scale to capture John Henryism. John Henry was the legend of a steel-driving, strong African-American male who engaged in this epic battle between his physical strength and a mechanical steel drill. He won the battle, but he died immediately after in victory because his heart gave out. So he won, but he died. And so Sherman James developed a John Henryism scale that captures an active coping style, perseverance, commitment to succeed against all odds, working hard to disprove the stereotypes. But what he finds is that for middle-class African Americans who have high on John Henryism, it's fine. But for low SES African Americans, you are struggling to succeed, but lacking the resources to facilitate success, is linked to worse health, particularly elevated rates of hypertension in his early studies. We need to understand this phenomenon and figure out what we can do about it. Another area that is important, we need to better understand the resilience factors and resources that can cushion the negative effects of all these stresses on mental health. Here is a study by Gene Brody and colleagues that illustrates what's possible and the power of psychosocial resources. This is a study of Black adolescents in Georgia. Their discrimination levels were assessed at age 16, 17, and 18. And those kids who were high on discrimination at 16, 17, and 18, by age 20, I didn't say age 40, by age 20, they have higher levels of stress hormones, cortisol, epinephrine, norepinephrine, higher levels of systolic and diastolic blood pressure, higher levels of inflammation, higher BMI. At age 20, systemic biological dysregulation linked to discrimination as a teen. But what the researchers found were that those kids who had high levels of discrimination, but had high levels of social support, emotional and instrumental support from their caregiver, from their peers, from their teachers, the support broke that relationship, erased the negative effects of discrimination on their well-being. So the power of social ties, supportive social ties, the power of community. Here is a national study of African Americans that found, yes, discrimination leads to worse mental health, but religious attendance and church-based social support and seeking religious guidance in everyday life reduce the negative effects of discrimination on mental health. So religion as a potential resource. And here is work from the First Nations communities in Canada that looked at the relationship between suicide, a youth suicide, and what communities were engaged in. At the time of this study, First Nation communities in Canada had arguably the highest rates of youth suicide in the world. But researchers nonetheless found that in more than half of these First Nation communities, there were no youth suicides. So they wondered, they're very disadvantaged globally, but in half of them, there are no suicides over over a 5-year window. They identified a number of markers of challenging the government for titles to land, for a right of self-governance, for control over services, for having a building to celebrate their cultural activities. And what they found was each indicator of advocacy, of protest, of empowerment, of cultural affirmation was associated with lower risk of youth suicide. And that there was a strong dose-response relationship between the numbers of markers of protest, advocacy, and empowerment and suicide. So there might be health benefits to the Black Lives Matter movement. Before I close, I want to point to some ominous storm clouds that we need to pay attention to. This is a study that has left me very worried and disturbed. It's a study using national data on suicide among elementary school children in the United States. I don't know that if when I was in elementary school, I knew what suicide was. This is national data on suicide among elementary school students in the United States between 1993 and 2012. What they found, levels of suicide have remained stable for Asian and Latino children in elementary school. For white children, the levels of suicide have actually declined. For African Americans, it's true for African Americans in general, I'm showing you the data here for boys, the level of suicide among elementary school students has doubled between 1993 and 2012. What does it mean to be growing up African American in American society today? And what does that mean for the future of our children? This is an ominous storm cloud that we need to work on together to solve. I leave you today with the words of Martin Luther King. It may well be, he said, that we will have to repent in this generation, not merely for the vitriolic words and the violent actions of the bad people, but for the appalling silence and indifference of the good people. There are real challenges of stress, and COVID-19 is only making it worse within our communities today. And we cannot be silent, and we cannot be indifferent, but together, let's bring our resources together to improve the physical and mental health of our populations. Thank you very much.
And thank you, Dr. Williams, for that inspiring presentation, and also for the new data that you presented us today. I'm wondering if there's any questions in the chat, or if there are other questions that came through the Q&A feature. Oh, I see where it is. So, Dr. Williams, I had a question for you, which was about early on in your slides, when you were talking about school-age children, and you broke them down according to race and the incidence of ADHD and
Yes.
conduct disorders and some of those things. And a question I had for you is, I wonder if sometimes those diagnoses aren't made, that in itself is a form of discrimination.
Very, very good point. I mean, you, as you well know, there is a literature that has shown historically that the same symptoms are presented in a patient, that the race of the patient determines what the diagnosis is. We would hope that with more standardized measures that this occurs less frequently than it historically did occur. But I mean, there is a literature in psychiatry and mental health psychology that documents the misdiagnosis of symptoms, where a given symptom being viewed as much more negative or more predictive of severe disorder in populations of color.
Yeah, that also makes me think about, too, in terms of treatment. I know there have been studies about adults receiving treatments for medical disorders, and that if they were a person of color or a person with a psychiatric diagnosis, they often got different kind of treatments then. So that there's some bias on the providers.
Yes, you are absolutely correct. There's absolutely no question that there is provider bias. A long time ago, back in 1999, the United States Congress voted to ask the Institute of Medicine, today called the National Academy of Medicine, to answer a simple question. And the question was this: what happens when African Americans and other minorities enter healthcare contexts in the United States? Does your race or ethnicity determine the quality of intensity of care that you receive? And so a committee was established, 1999 to 2002. I served on the committee. The report released by the committee, published in 2003, is entitled Unequal Treatment. And what the report found was across virtually every therapeutic intervention, from the most simple to the most complicated, populations of color receive poorer quality care and less intensive care than whites. I'll give you one example of a study that illustrates what we found. Dr. Knox Todd was an emergency room physician at UCLA Medical Center, and he asked a simple question. When a patient comes into the emergency department with a long bone fracture, that's medical speak for a broken bone in the arm or leg, does your ethnicity determine whether you get pain medication or not? And he found that 56% of Latinos who had been treated at UCLA with a broken bone in the arm or leg in the prior year had not received pain medication, compared to 26% of whites. He was a good researcher. He said confounding. He statistically adjusted for what time they got injured, what time they showed up at the ER, were they injured on the job, did they speak English or Spanish, what were the characteristics, what was the severity, and after statistically adjusting for everything, it only made the findings stronger. Latinos were 7.5 times less likely, adjusting for all these confounders, to not receive pain medication, and the biggest predictor of not receiving pain medication was being Latino. Yeah. So he went to Emory University in Atlanta, repeated the same study looking at blacks and whites in Atlanta, and found exactly the same thing. And it's when I tell the story of these studies, folks don't focus on pain medication. This pattern has been documented in every area of medicine. There were more studies back in 2003 in the area of the treatment of cardiovascular disease than any other area. And since 2003, there have been many published papers that document the persistence of it. So we think implicit bias is operative in leading to the negative stereotypes that many of our providers have as a result of this society in which they were raised, leading to poorer quality care and less intensive care for all populations.
So true. We have a couple other questions. There's one from Rebecca Singer, who asks, with the experience and outcomes being so different by race, how should our interventions be adapted? Are the interventions that have been effective for white folks been just as effective with people of color? And what work is being done in this realm, if you know?
That is a great question. I would say in many areas of research, we haven't done this. We haven't looked for differential effects. I think there are studies that have looked. I mean, you think of the early childhood area. I would give that as an example. Think of the nurse family partnership model with David Oles, and he did a study with vulnerable pregnant women, having a nurse visit them. And he did a randomized controlled trial in upstate New York with predominantly white population, one in Memphis, Tennessee, with predominantly African-American population, one in Colorado with a predominantly Latinx population, and documents the same pattern across those studies. That's a good example of what we need to do more of. I think in many cases, yes, we see similar findings. Maybe in other cases, there may not be, but we haven't systematically looked at it as thoroughly as we could. But that would be a good example, David Old's work, of an explicit attempt to look at different conditions, different populations, and finds that this works. And basically what he found was that having a nurse make home visits to vulnerable teen moms, and they talked not only about the health of the mother and the health of the child, but talked about their social well-being and their economic prospects and their relationship with the child's father. What they found was that this intervention led to improved outcomes for the child, improved outcomes for the mother, and saved society money. Even though it's expensive to send a nurse to make a home visit, it saves society money in lower welfare costs, lower social service costs, lower behavioral problems costs. So there is that kind of evidence there that points to things that we can do.
Mm-hmm. Great. And then there's a question from Andre Tamlin, who's I know is in Great Britain. So his question is mental health research itself racist? Are we including all the people we should in the studies? Are people from diverse communities leading large research studies?
I know in London there's at least one study that I have a colleague, I actually work with her, that is working in looking at a diverse population of immigrants in London, in the UK. So there are studies along those lines, but he is right. There is a history across on both sides of the Atlantic of work that has been done, as we mentioned before, that didn't pay attention to biases seem to seep into the decision-making process and the clinical decision-making. And there's still challenges of how our populations, the disadvantaged minority populations, are treated, you know, by the criminal justice system and the mental health system, and so forth. But I think, on the other hand, there are ways in which we are getting more persons from populations of color backgrounds into these services, and I think that does make a difference. There was a study published in PNAS, a major journal, just last month, that looked over multiple years in the state of Florida of births, and found that on average, that Black babies who were born, who were treated by Black physicians, had a markedly lower rate of death in the hospital than Black babies who were treated by white physicians, suggesting that there is some benefit to race concordance. And we still face challenges in the United States with the number of healthcare providers across multiple healthcare disciplines that we have from Latinx backgrounds, from African American backgrounds, from Native American backgrounds, from Pacific Islander backgrounds. So that is an area where we have a lot of work. There was a report from the American Association of Medical Colleges in 2014 that showed there were fewer African-American males in the first year of medical school in 2014 than in 1978. So we have work to do in developing the pipeline programs that prepare young people from disadvantaged communities to be successful in the health professions as well as in other areas.
That's amazing. Do we have time for another question? Do we have
There's actually a question that just came through in the chat box.
Okay. The question is, any thoughts on some strategies that might be important to implement in healthcare settings to address systemic racism, aside from focusing on individual level interventions like unconscious bias training?
This is a really great question. There has been enormous interest in implicit bias, which is a factor. There is some research suggests that under very strict conditions, there can be interventions that reduce implicit bias, and that those reductions remain effective over I'm thinking of work by Professor Patricia Devine at the University of Wisconsin. 3 months later, the reductions are still evident. But I think it's fair to say, if you look at the literature on a lot of the kind of culturally competence programs, they do not seem to have long-term staying power in reducing implicit bias effectively. And it points to what some researchers are now talking about, of the importance of developing not only cultural competence, but developing structural competence. And what they mean by structural competence is that the implicit biases that have affected individual behavior and beliefs and affect interactions with patients have also been baked into our policies and our procedures and the way our institutions are structured. And so it's not simply about addressing implicit bias at the individual level, but it's really thinking also as how those biases have shaped our normal routine functioning processes and policies. I do think that is a promising direction of paying much more attention to structural competence and really giving more effort and interest to doing the effective policies that would or interventions that would reduce implicit bias.
Yeah, amazing. Okay, I think we might have time for one more question if there's any others. I just want to say, Dr. Williams, that I think one of the takeaways I have from what you've presented today is the importance of things like empowerment of Blacks and people who are discriminated against. And, you know, the example you gave from the Canadian study, yes. and just, I think you just made a comment, but I think it really bears repeating, and that's that there can be lots of benefits from the Black Lives Matter movement. Yes. And one can be, you know, young children seeing people having power and having rights and being heard. So I think that's a message I took away from what you had.
Yes, I think that is a good point. I completely agree. There are not a lot of interventions, but there are a couple of interventions that have used racial pride and have built into this intervention that is trying to comprehensively deal with the challenges that young people are facing, but also includes specific curriculum on affirming their sense. There have been these studies with Latinx youth and African-American youth that including a racial pride component leads to better outcomes. And so, yes, there are those possibilities, and those are things that we need to strengthen for our young people today.
Yeah. Well, if we have no more questions, I want to just remind people, and of course this will be on demand, this presentation, until January 5th or 6th, I believe. And I want to thank everyone for joining us today. And again, I want to thank you, Dr. Williams, for a, like I said, most inspiring presentation.
Thank you so much. It's been a pleasure to be here with you. I wish all of you everything good, and do keep safe and stay well. Thank you.
Thank you. Thank you.